Welcome, everybody. I'm Paul Shyn.
And I'm Dan Souza, and we're going to be presenting science and sorcery for tackling impossible biopsies and drainages. We have no disclosures. And Paul, I think it would be helpful to start off by maybe defining what we mean by an impossible procedure, an impossible biopsy.
Yeah, I think, Dan, first of all, impossible, of course, is we're using it as a relative term. But I think an impossible procedure might be one where a feasible technical approach is not immediately apparent, or maybe that we think that the probability of a safe and successful outcome is low, so we don't have much confidence that we're going to be able to pull it off. Or during the procedure, maybe it becomes suddenly much more difficult than we thought and becomes almost impossible. So, why do we want to up our game? I think one of the things to realize is that when we decline a procedure, that can have major implications for the patient. It can delay treatment, it can necessitate a surgical intervention that carries greater morbidity, and it can lead to poorer outcomes for the patient. So the more experience we have and the better our skill set and techniques, the better chance that we can improve our patient outcomes with safety and better results.
That makes sense.
So although this won't be a comprehensive course on cross-sectional intervention, we'll try to cover a lot of teaching points. So Dan, why don't you get us started in the kidney, and we'll start winding through as many cases and scenarios as we can.
Sure, Paul. This is a patient that came to us with a history of ovarian cancer. She had a very deep left renal pelvic mass. And the question was whether she was having metastatic disease or a primary urothelial cancer. As you can see on the MRI, the lesion was very, very central, located within the renal sinus and the renal pelvis. We decided to approach this mass by using a fine needle and CT guidance. Luckily, the patient had a ureteral stent, and that allowed us to know exactly where the mass was. We placed the introducer needle, a 19 gauge introducer needle, by using a posterior approach with the patient prone. And through the 19 gauge, we got 22 gauge needle biopsies, and we were able to get to the diagnosis by minimizing the risk of bleeding.
Yeah, I think that's a great example. I have a similar case where we did a renal sinus mass, and we also put in a 20 gauge tuba introducer. And then through that, we did 25 gauge coaxial FNAs. And, these small gauge needles are, you can do FNAs pretty safely with little risk of injuring a blood vessel or a collecting system structure. If the mass is very large, you can do a core biopsy as long as the core biopsy device is entirely within the mass, the sampling slot. And sometimes what I'll do is I'll put the core biopsy device deployed in the mass and then do a CT angiogram before snapping the core, just to make sure I'm not on a vessel. Or you can even do a delayed expiratory phase scan to make sure you're not sampling the collecting system.
That's a great case, Paul. Since we're talking about renal mass biopsies, we oftentimes get asked to biopsy cystic masses in the kidney, like Bosniak 3 lesions. Do you have any tips on how to biopsy cystic masses in the kidney?
Yeah, these can be challenging because they're not as substantive. And so, like in this case, what we tried to do was to sample the wall with our core biopsy device. But initially, we really were not getting diagnostic material. So we advanced our introducer a little bit further and aspirated out the fluid, which you can send for cytology. But that's, of course, low yield. And then we took a core biopsy of what was remaining, and that gave us enough tissue to make a confident benign diagnosis in this case. Sometimes with cystic masses, especially if I'm not going to be sampling any normal renal parenchyma, I'll use a larger 16 gauge core biopsy device in the hopes of getting more of the septations and nodularity of a cystic mass to increase the chances of a diagnosis. This was another patient that had a cystic mass elsewhere in the body. This was in the paraspinal muscles, a lung cancer patient. Here we placed the needle, and we noticed fluid coming back when we took out the stylet. So we aspirated as much fluid as we could and then did the core biopsy, confirming a metastatic tumor.
Interesting. Another thing that I noticed, Paul, when I'm doing renal mass biopsies, sometimes you can have bleeding very early in the procedure, and that can obscure, especially if the target is small or subtle. How do you avoid that from happening?
Yeah, I think, this is an example where, it's a small cortical renal mass that's hard to see. And then with the first needle placement, there's a little bit of hemorrhage. And it can be very frustrating because the hemorrhage can completely obscure the target, and it can be very hard to get back confidently into the target. And sometimes you actually, find yourself rescheduling the procedure and starting over. So a couple of things that you can think about, of course, if IV contrast doesn't help, what you can do instead is approach the mass from a little bit further away. So I sometimes like to do these cortical masses by entering a little bit further away in the cortex. And when the needle is in the cortex, I stay close to the capsule to minimize the risk of injuring a vessel. And then you can incrementally advance your needle and correct the angle to make sure you're dead center on the small renal mass. And then you deploy your cord biopsy device or get your FNAs. And when you take your coaxial needle out, you still have purchase and you're right on the mass. So if you need to go back and get more samples, it's a cinch to do, even if the lesion is obscured by hemorrhage. And notice here the core slot is entirely within the mass. We try to avoid the capsule itself when we
Mhm.
take the biopsy. Another thing to remember is that if you're doing a superficial small lesion biopsy, when you put your core biopsy needle in the mass and snap the core, it's often tempting when you pull to just pull out your core biopsy needle, and your introducer needle may not be in the mass, and then you've lost purchase. And could have been your only chance to get the sample. So instead, slide your introducer in before you pull out your core biopsy needle, and that way you've still got purchase if you need to go back for another sample.
That's a great teaching point.
And so here's an example where we did that. We got our core biopsy. Notice the introducer was really not in the mass. And if we had just taken out the core biopsy needle, we would have lost purchase, but instead we slid the introducer in to maintain purchase. So Dan, I think adrenal biopsies are a little bit intimidating for the novice. And so how do you typically approach these?
Yeah, so although it may be tempting to start off by doing biopsies in the adrenal with the prone position, we found that the best position is actually with the ipsilateral side down. So, for example, this is an adrenal mass biopsy in a patient with unresectable pancreatic cancer. You place the patient with the right side down. That allows you to push the lung away from your target, and then you can very safely get your needle into the mass and perform the biopsies with no issues. And that is occasionally the case with the vast majority of examples. I have a few other examples. The next case is a 74-year-old male patient with esophageal cancer, now with the left adrenal mass biopsy, adrenal mass suspected for metastatic disease. It's important to keep in mind that if the patient is unable to be in lateral decubitus, the more prone the patient is located or situated, the more lung you're going to have in a way. So make sure you're assessing your lung windows to make sure the lung is not in a way. The patient was slightly prone here, not entirely lateral decubitus, but we were able to perform the biopsy with no issues. The next example is also a patient with the lung mass, left adrenal mass. We placed the patient with the ipsilateral side down, and we were able to perform the biopsy without any complications. And the post-biopsy procedure showing the gas within the mass that confirms that we were in the right spot. That's another helpful tip to know we were in the right spot. The next case is a patient with a 55-year-old with the breast cancer. You can see with the lateral decubitus, it was not an ideal position because the kidney was actually in the way. So we placed the patient slightly more prone, and that allowed the kidney to drop a little further, and we were able to biopsy the mass without any issues. So it's always helpful to play with the patient positioning to try to get things out of the way to perform safe biopsies.
That's a great point. Sometimes very subtle differences in position can make all the difference.
Yeah, it gets a little more tricky in examples of, for example, in this patient with metastatic RCC, the patient had had a prior right radical nephrectomy. So the window that we had to get to the mass was a little more narrow because it was squeezed between the lung and the bowels of loop that were filling the nephrectomy bed. So we had to use an angled approach, coming a little bit more inferior, more caudal, and aiming a little bit more cranial. The tip was actually in the mass, and we were able to perform this without any issues. This is another example and another strategy that you can use for adrenal mass biopsies, the right adrenal mass. We try to use the lateral decubitus approach at first, but the lung was in the way, and you can confirm that with the lung windows. And we decided, given that that's the luxury of doing right adrenal mass biopsies, that you can always think about using a transhepatic approach. And I find that when you're doing transhepatic approaches, it's best to use ultrasound because that can help you see real time all vessels and ducts that are on the way, and you're able to perform the biopsy very safely using ultrasound.
Yeah, Dan, that's a great example of a transhepatic approach and how it can save the day. A similar situation sometimes occurs when we're draining subhepatic abscesses on the left or the right. And if there's only a transhepatic access, as long as we avoid the portal bundles, the portal vein, hepatic artery, bile duct, it's usually very safe. So, this is another example of a transhepatic procedure where we're doing a biopsy. This was a pancreatic cancer recurrence after a Whipple. And, anteriorly, there wasn't really a safe access, vessels, bowel, and liver. So instead, we thought we might come through the hepatorenal fossa, but when we turned the patient up obliquely, that space kind of narrowed and the cava was in the way. So we elected to go transhepatic. And under CT fluoro, you can nicely navigate incrementally and correct your angle as you go to get through really small, tight spaces, as we did in this case, and got into the target to do the biopsy. We were pretty peripheral in the liver, so we were comfortable doing this under CT. But as you pointed out, Dan, I think ultrasound is also a nice way to do this so that you can see the vascularity and avoid the portal structures. And this is just another example of using color flow Doppler for a liver biopsy, and we're watching our needle go between blood vessels to get into the target.
Nice. So Paul, I know there's a commercially available biopsy needle system that can bend or curve the distal end of the needle. Do you ever use this system?
Honestly, I've never used that system, but there's a pretty simple, inexpensive way to do it with standard needles. So for example, I'll often use a 20 gauge Chiba needle and through that put either a 23 or 25 gauge Chiba needle. And you can curve the very end of the smaller gauge needle to direct it. So for example, this was a very small adrenal nodule that we were biopsying, and we had kind of a tight window and we were just off target. So we curved the needle to get it into the nodule and get the diagnosis. This was a similar example, small adrenal nodule. The needle was just on the eccentric aspect of it. So we curved the needle to get into the meat of the nodule. And notice that if your introducer is right on the target, you may not have enough room for the needle to curve into the target. So you may need to pull your introducer back a centimeter or more so that the curved needle will navigate into the target. And this is how I curve the needle. I hold the hub to see where the notch is, and then I direct it into the palm of my hand so I know which way it's directed. And then with my fingers, I curve the needle away from the notch, or you can use a needle driver to do this. Just make sure it's a gradual curve and not an abrupt curve. And so the curve is pointing away from the notch side of the hub, and that helps you keep track of what direction it's going to go. And then you insert it into the hub of the larger needle, the 20 gauge needle in this case. And once you get the needle in, you'll feel a lot of resistance until the needle comes out the end, and then the resistance drops off, so you know it's coming out the needle. And then you can do your fine needle aspirate that way, always knowing which direction the curve is going because of the hub.
I see.
So, this is an example. This was actually a celiac neurolysis with alcohol, and there was this whole area was socked in with tumor, but there was a small fatty gap, and we got our needle pointed just around the aorta, and then curved the coaxial needle into the space between the celiac trunk and the SMA, And this allowed us with a single needle to inject contrast to confirm flow on both sides and then put alcohol in for a successful neurolysis. And a similar example, this patient also pancreatic cancer with intractable pain. And we incrementally advanced our needle into this gap, injected contrast, which flowed on both sides, and then the alcohol. And the other thing, you showed a case, Dan, where you were sliding along a liver capsule with a diamond tip stylet introducer. And this is a bevel tip needle, and both needles can be slid along a capsule, usually very safely, as long as you push slowly and you're going tangential. The diamond tip is nice because of that sort of beveled tip. On the cutting needle, it also has a bevel, and if you turn the bevel so that it faces the critical structure, whether it's a blood vessel or an organ, it will tend to slide off of it and not lacerate.
So Paul, I have a question about intra-aortic cable biopsies. Biopsying those small lymph nodes between the aorta and the IVC can be rather unnerving for trainees. How do you approach these?
Yeah, so the nice thing is that these are typically fixed structures, and so as long as you can find a straight line access, it's very safe and relatively easy to do once you get used to it. The idea is to choose a trajectory so you're not pointed at the main vessels like the aorta or the cava.
Mhm.
We want to go between them, and so here's the adenopathy. And as you under CT fluoro place your introducer needle, you just incrementally adjust your angle so that it's right on target as you go through the narrow gap into the adenopathy. And then you can do an FNA or a core biopsy. Just don't go too deep to injure bowel or vessels that are deep. This is a similar case where it was a smaller gap and smaller lymph node between the aorta and cava. And one thing to think about is that when you take a core biopsy here, if you're really right on the or almost right on the vessel wall, you may want to turn the slot of your sample away from that vessel so that when you fire it, it's less likely to injure the vessel.
I see.
And then, of course, you can sometimes get to it laterally or anteriorly, depending on the arrangement of the bowel. And so those are also, of course, options. So, Dan, what are some other thoughts you might have on approaching deep targets?
Well, the first thing is trying to get an optimistic view and be positive about it. This is a patient, for example, that had an ureteral cancer, had a ureterectomy, had an ileal loop, and had a very deep left iliac lymphadenopathy. On looking on the planning scan or the diagnostic CT, there were several obstacles that could be potentially in the way at the time of the biopsy. The ileal loop was a little distended. There were some bowel loops in the way. Luckily, when the patient was brought to the CT room for the procedure, the ileal loop was completely decompressed. The bowel was not on the way. We were using CT fluoro, like the example you showed very nicely. You can go step by step, centimeter by centimeter, navigating your introducer needle very deep into the lymph node. One thing that is very helpful to optimize the visualization of the target is to pull the inner stylet as much as you can, and that will decrease the amount of artifact at the needle tip, of the introducer needle tip. Once we thought we were in a good position, we advanced the biopsy needle and the tray out within the lymph node. We obtained a spiral acquisition to confirm the location, and we were very convinced that we were in the right target. Another example of a perforated sigmoid diverticulitis is a fairly deep pelvic abscess. The patient was not a surgical candidate. On the diagnostic CT, there was a lot of bowel surrounding the abscess. It potentially would be a tricky or nearly impossible drainage to perform. But once the patient was brought into the CT room, we saw that the bowel that was inflamed was pretty fixed, and it didn't move at all. That's something I noticed with the sick bowel or inflamed bowel adjacent to abscesses. They tend to be a little bit more fixed. And that made us comfortable to get the introducer needle, the Chiba needle, into the abscess, navigating between the bowel loops using CT fluoro, getting the wire in using Seldinger technique, and properly draining this pelvic abscess with a 12 French catheter.
Very nice. And then how do you use hydrodissection?
So hydrodissection can be helpful when you have some especially bowel in the way. This is a patient with a left pelvic sidewall lymphadenopathy, suspected lymphoma or metastatic disease. As you can see, the patient was very, very thin, had some ileus and some gas-filled colon that was in the way. There were some vessels in the way. What we did was we brought the patient to the CT room. Obviously, we couldn't see the lymph node with ultrasound, uh, but under CT guidance, we placed a spinal needle, very, very superficial. We started injecting saline to try to displace the bowel away. And you can see with progressive CT fluoro images and progressive injection of saline, the bowel was slowly being pushed away from the lymph node. Once we felt we had a safe window, we removed the spinal needle, got the introducer needle back in, and placed it inside the lymph node, and were able to perform the biopsy without any issues.
Beautiful. I have a similar case. This was also a left external iliac lymph node sitting right on the iliac artery and vein. We could maybe have come anteriorly, although this bowel was mobile and we weren't sure the window would be there. But even if we could, the problem is that this was a fairly thin lymph node and we would have been pointed right at the vessels, and we didn't want to poke the vessel to cause bleeding or seeding tumor into the bloodstream. So we really wanted to come from a more lateral approach. And so we placed a needle in the space between the iliacus and the bowel and injected dilute contrast. We usually put about 30 mils of IV contrast into a liter bag of normal saline. And then that gave us a straight line access to this lymph node that was tangential to the iliac vessels. And we did an FNA for the diagnosis here. Could have done a core also, but it was just a nice way to optimize our approach.
I like how the iodinated contrast can really allow you to see better the polyps being displaced, and that may be an advantage over injecting saline for hydrodissection, right?
Yeah, I think so. So for example, this patient had an iodine allergy. So when we did the hydrodissection, we used saline, similar to your first case, and it did allow us to get the bowel out of the way. And then we put our biopsy needle in and made the diagnosis. But we pre-medicated her for the next procedure, which was an ablation procedure to destroy this lymph node. And we did IRE, irreversible electroporation. And this time we used dilute contrast. And notice that we came from the right, we're pushing the bowel to the left, and we kind of chase the bowel with our needle as we inject the contrast and then put our probes in. And then that allowed us to do the ablation successfully.
Nice.
This was a mediastinal abscess, a young man with a esophageal leiomyoma that was resected. And as a complication, there was a big defect in the esophagus that led to a mediastinal abscess. And so we incrementally advanced our needle in a paraspinal approach, and it was a pretty narrow gap. And just to make sure that we were safe here, we injected some saline to expand this space, and then put the needle into the abscess and the catheter, which did straddle this large defect and was partially in the esophagus and partially in the abscess. And then in conjunction with thoracic surgery, the plan was to just very slowly over a period of months back the catheter out, which we did. And that allowed the hole to heal over many weeks without a residual abscess.
So Paul, you showed some examples of CT fluoro, and I noticed that some interventional radiologists rarely or never use CT fluoro, and instead rely only on helical CT acquisitions for their CT guided procedures. In my old practice, we didn't even have CT fluoro for CT guided procedures. Luckily, at the Brigham, we do tend to use these routinely. What are your thoughts about CT fluoro?
Yeah, I think CT fluoro really opens up possibilities, and you can do a variety of things with it. I find that it allows me to do some very precise things that would be difficult to do if you had to step out of the room every time you got a scan. I think the hesitation that some people have it has more to do with radiation dose to the operator. But there's a number of strategies to minimize that, and it ends up being a pretty low amount of radiation exposure. But number one, use a low technique, the lowest possible. So we usually default to about 30 MAS for our CT fluoro acquisitions. And you can step back when you take fluoro images, which is very, very helpful. You can even put a lead drape over the patient's body below the field to decrease scatter. And then, the most CT scanners have software that does these partial rotations on the opposite side of the patient. So that helps also minimize scatter to the operator. But anyway, what I love about CT fluoro is it allows me to very quickly do complicated procedures. And, one is just being able to sort of incrementally zigzag your way beyond past critical structures into a deep structure like this pancreatic abscess, for example. And we'll show other examples later in the talk. But one thing that capitalizes on CT fluoro is this 3D printed compression device that we came up with and described back in 2017. You can actually download this software, this data file to print your own paddle at this website. And this is what it looks like. It has a keyhole cutout in the spoon that allows you to put the device around a needle. You can also put a sterile ultrasound probe cover over it and secure it with rubber bands. If you have a needle or a device in the patient, you can move the patient into the gantry. And as you apply compression, you can also steer the needle in any direction with the device. And then you can take a picture, a CT fluoro image with the needle deflected in any direction. And your hand is out of the beam so that you don't get radiation, direct radiation to your hand. So for example, this case was a small mesenteric root lymph node that we needed to biopsy and also place fiducials around for radiation. We used compression ultrasound to get rid of these bowel loops. And that's, of course, a great strategy for getting around bowel loops in the abdomen or pelvis. But as you can imagine, although we had our vascular landmarks, this lymph node was actually not visible to us under ultrasound. So we placed our needle and then confirmed with CT that we were actually where we thought we were and then took our biopsy. But then for the fiducials, I went ahead and used the compression device and CT fluoro to place my needle and place the fiducials. Another similar case, a patient with a lymph node at the mesenteric root, suspected recurrent pancreatic cancer. We tried compression, but it wouldn't get the bowel loops overlying the area of the lymph node out of the way. So we came more inferiorly and found a gap that we could advance our needle into. And then using the compression device, we angled sharply towards the head and incrementally advanced the needle into this lymph node. And to show you what this looked like on spiral CT, you can see the needle here coming underneath small and large bowel to get into this mesenteric lymph node for biopsy.
Beautiful case.
And then another example, superficial bowel loops that are in the way, and also deep bowel loops on top of this common iliac lymph node. And here compression was very helpful, not only in steering, but getting the bowel a little bit of a gap between the bowel loops so that we could advance between them. And then when you get deeper, it's harder to displace bowel loops with compression, but you can still steer your needle around structures with the compression device and check your position under fluoro. And so we found a gap and went through and got into the common iliac node for the biopsy. And one more example, a superficial bowel loop in the way with compression, it nicely moved out of the way and allowed us to do the biopsy.
Beautiful example.
So Dan, I think many people are uncomfortable with targeting masses at the liver dome. Can you begin with some of the options you consider when you approach these lesions?
Sure, absolutely, Paul. This is an example of, of a liver dome mass that we could approach by using CT or ultrasound. That's the case with the majority of liver mass biopsies. You can use different strategies to obtain successful results and similar results. So at first, the patient had an FDG avid mass in the liver dome. It was performed under CT guidance, and we were able to get a diagnostic specimen. The patient came back a few weeks later because she was on a clinical trial, and we ended up doing the biopsy under ultrasound. So both strategies were successful. You can choose the strategy that you're more comfortable with. But in some examples that we're going to be showing, one modality will prevail over another modality. So this is an example of a patient that had a liver dome mass. The lesion was not well seen with ultrasound, and we had to do a CT guided biopsy. And the way that we did this, because of the location of the mass, was by using an angled approach. I usually typically will look where the target is. I will scroll down to where I want to enter with my introducer needle. And then I'm going to angle towards, using CT fluoro, I'm going to angle towards the target. And we were able to get, enter lower down below the lung basis. We had to use a transpleural approach or intercostal approach, but we were much lower than you would be if you were in plane. And then angling up and advancing the introducer needle, we got very close to the mass and we were able to get diagnostic specimens without any complications. Sometimes using multiplanar reformations may be helpful to redirect your image as you go, so you feel more comfortable by placing your needle. And this is one example where we thought we were in the mass. We were pretty confident, but by using the MPRs, you can be unequivocal about the location of your biopsy tray. And also looking at the post biopsy images are very helpful. I usually call this the cherry on the cake when you see the gas within the lesion. The gas within the mass is diagnostic that you were there and you were getting diagnostic specimens within the mass. So, Paul, what is your usual preference for targeting liver dome masses?
Well, like you, Dan, I usually like to use ultrasound. I think it's the simplest, most straightforward way to angle up into liver dome lesions. But if for some reason I'm not going to use ultrasound, approaching the dome with CT, a lot of times I find a subxiphoid or epigastric approach is a good one because my needle is sort of directed away from the heart but up into the dome, and I can incrementally advance it into the target that way. Um, but also, if you're coming from the right side, as the example you showed, you can start low below the lung and angle up into the target this way.
Nice.
Uh, some people, like to do the multiplanar reformats, which I think you should do, if especially as you're gaining experience. But once you have a lot of experience, you can often comfortably angle up out of plane and just follow the needle under CT fluoro. So Dan, can you show us some examples of where you used ultrasound for guidance?
Sure, absolutely. There are a few examples where ultrasound can be particularly helpful in biopsying liver dome masses. This is a patient with an unresectable pancreatic mass and a liver dome mass. You can see how challenging this could be by using CT, but once you get the patient on ultrasound, usually I like to get the patient in an LPO position, a slight left posterior oblique position with the side up a little bit. With an oblique approach, you can see the lesion really well, fairly well. You can see the diaphragm. And then the beauty of ultrasound is that you can change your angle, your transducer angle slightly, and choose the approach that is going to be the safest to avoid any large vessels or any bile ducts along the way. So in this example, we performed the biopsy under real-time ultrasound and we had no complications. We got 5 cores of that lesion. Another example, a patient with lung cancer had a liver dome mass, very similar example on a PET. There's an FTG avid lesion right at the dome. You can see how challenging this could be with CT. Once you have the patient in the LPO position, an intercostal approach coming from below, you can very safely see the lesion, avoid vascular structures, avoid the bile ducts, and get diagnostic specimens. And you can see the post images, no complications. Another example of a liver mass in a patient with a history of melanoma. The liver biopsy was for clinical trial, so we would need to get multiple specimens. We brought the patient to the CT room, but we used ultrasound to make sure we could see the lesion. We could see the lesion exquisitely well, and we used, again, an oblique approach coming from below, patient LPO, and we were able to get multiple diagnostic specimens of the mass without any immediate complications.
And Dan, this is a nice example of the sliding lung sign where you can see the lung very clearly under ultrasound, so you can avoid the lung as well.
Absolutely. And you can see we were able to get multiple cores there without any complications. As you can see, the more specimens you get, the more air is introduced into the mass. And that can be a pitfall with ultrasound. It may be harder to see the lesion. It may obscure your view. And that's why you have to be very, very particular about your technique. Try to introduce as little gas as possible, even if you're, as you're withdrawing the lidocaine for your initial numbing, you want to make sure there's no gas in the way, because even 1 ml of gas can completely obscure your view. Another example where I thought initially I was going to be doing with CT guidance. There's a large mass, relatively central, but I felt that the mass was easily accessible by using an LPO position and CT guidance. This was my planning route. I was going to go between the vessels with an LPO approach and get to the mass. When I placed the patient on LPO position, I felt that the lung was in the way. It was very close to the lung, and I decided to go a little lower down. But once I went a little lower down, I saw there were several vessels, and there was a big hepatic vein there right on my way to get to the mass. And I felt it would not be as safe to do this with CT. I decided to move to ultrasound. Once you get the patient in ultrasound, it's much easier to see the intervening vessels and plan for a safe approach. We plan for the safe approach. We measure the distance. You also want to make sure you take into account the breathing motion when you're planning for your needle length. By using real-time guidance, we were able to get to the mass and obtain safe biopsy. Another particularity of ultrasound is, and it can be particularly helpful in biopsying subcapsular masses or superficial masses, because you can see those lesions with exquisite detail. This is an example of a patient with gastric cancer, a subcapsular mass on MRI. Once we brought the patient to ultrasound, you could see the lesion really well, and we were able to get biopsies very easily. Even when the lesions are small, this is another example. Small liver masses in a patient with neuroendocrine tumor of the GI tract. The lesion was actually under 1 centimeter. Once we bring the patient to ultrasound, especially if the patient is thin, you can decide on which transducer you're going to be using. And you would be surprised to see that sometimes you can even use a linear probe that is used for musculoskeletal procedures to perform your liver mass biopsy. This is one example. The patient had a sub-centimeter mass. We initially imaged the lesion with a curved transducer that we use for most of our abdominal biopsies. We shifted to a linear transducer. We could see the lesion even better with the linear transducer. The only issue with the linear transducer, the 9 and the 15 megahertz, is that they have a large footprint. And I find it very helpful to use the hockey stick, which is still a high resolution linear transducer, but it allows you a lot of space to get to the lesion. And we ended up doing the biopsy with the linear hockey stick transducer safely.
Dan, I assume that works best on thin patients.
Absolutely. You never know what to expect, so it's always helpful to try. But obviously, if the patient is obese, the likelihood of you being successful using a linear probe diminishes quite considerably. This is another example, 77-year-old patient with unresectable pancreatic cancer, had a liver mass in the right lobe. You could see the lesion well with the curved. You could see the lesion architecture, and even the necrotic center much better with the linear transducer. We decided to try the hockey stick because it allows you, again, to get a smaller footprint, and you're able to get to the lesion much easier. And we actually performed the biopsy by using the hockey stick linear transducer. And you can also direct the biopsy needle to the place where you think would be less necrotic and more diagnostic, and give you more diagnostic yield.
Yeah, Dan, those are great examples of ultrasound for liver biopsies. If you had to do CT for this, one thing that I've found is that sticking directly into a subcapsular liver lesion is often tricky because of slight differences in respiration. And also it's very easy to lose purchase if the patient takes in a breath, so the needle will pull out. So a lot of times I'll just come from a more distant approach and come under the liver capsule from a few centimeters away. And that gives me room to correct my angle as I approach the lesion. And then I also maintain purchase as I get multiple samples.
This is another example of a subcapsular mass, prostate cancer, new liver masses. One of the liver lesions was very close to the heart, and we decided to perform this under ultrasound guidance as well. We used a linear transducer, and we tried to monitor real time where the lesion was, where the stomach was, And by using real-time guidance and fine needle aspiration biopsy, we were able to get diagnostic specimens and minimize the risk of complications.
Dan, I really like the way you came, the angle you chose so that you're not pointed at the stomach. You're basically came into the mass and then were pointed at normal liver so that there was no risk to the stomach at all.
Another example of, a fairly small liver lesion that you would think it would be impossible to biopsy under CT, patient with colorectal cancer. Once you bring the patient to ultrasound, especially if the lesion is superficial, these lesions are very easily seen, and you are able to, with real-time guidance, perform diagnostic specimens, as in this example.
And, a particularly stressful situation can be targeting masses that are near the heart. What are some strategies you've used in these cases?
Again, similar with the liver dome biopsies, I think it's very helpful to try to perform the biopsy under ultrasound, because ultrasound is the modality that will give you real-time visualization of all the critical structures. In this example, there was a segment 2 liver mass. We used ultrasound to visualize at the same time the needle, the biopsy or target, the mass, and also the heart. And by using ultrasound, we were able to monitor the location of your needle tip at all times and make sure we were short of the heart and not pointing at the heart or overshooting it.
Yeah, and as we've alluded to before, the echogenic track, once you take one biopsy, can be confusing because sometimes it obscures your needle, and so it's very important to keep track of exactly where your needle tip is, and not go too deep, thinking that this is the tip of the needle. One trick I sometimes use is when my needle is in place, I'll, instead of jiggling the needle kind of in a long axis compared to the needle direction, I'll actually torque it laterally so that I can see it, the tip deflecting perpendicular to the length of the needle. And sometimes that helps you see the tip better.
That's a great point. Yeah, this was a tricky case, because obviously you want to try to use ultrasound whenever you can, but I couldn't see the lesion with ultrasound. The patient had a liver lesion that was very high up, just beneath the heart. And we brought the patient to the room. Since we couldn't see the lesion with ultrasound, we decided to proceed with CT guidance. The problem with those biopsies is that the patient's breathing can pretty significantly change the position of the liver mass. And the approach that we used in this particular case was we started the sedation before the procedure started to minimize the amount of breathing, or to be more predictable about the breathing. We also coached the patient to try to mimic or repeat the same amount of breath hold each time we were advancing the needle. And we ended up asking her to do full inspirations when we were advancing the biopsy, so that we could know exactly where or how low the heart could get, and so that we would actually be beneath that level to minimize the risk of injuring the heart in this case. It was a very stressful situation, so I would be very happy to know if you have any other tips or any alternative approaches to lesions like this.
I mean, that's a very impressive biopsy. I think one possible alternative would have been to come through the subxiphoid area from the right side and angle through this space into the
Mhm.
liver. And even if you start a little bit lower, angling slightly towards the head, and then incrementally advance it until you're in the mass, so that you're able to confirm that you're not, getting close to the heart. But that might have been another approach also. I find that with deep inspirations, it can be a little bit tricky to get into the target precisely, but more significantly, when they exhale, sometimes the needle will pull out if it's not deep into the liver.
That makes sense. So, Paul, in terms of anatomical landmarks in the liver, what are the landmarks that you find more helpful to doing biopsies when you can't see the lesion really, really well?
So that's a problem that comes up very often, especially with small, subtle liver lesions that are hard to see on ultrasound or CT. And so one of the things I find is that for small targets, if you can find a landmark that's right next to the lesion or within a centimeter, that's your best bet. So for example, this was a 1 centimeter arterial enhancing lesion that did not wash out in a patient with risk factors for HCC. And so we wanted to confirm HCC. A non-contrast CT, the lesion was isodense. We could not find it with ultrasound. But we did notice that on the MR, there was this slight capsular irregularity that was really close to the nodule. And so we used that to target the initial needle placement. And as you said before, we pulled the stylet back, did our arterial phase contrast scan, and saw that our needle was pretty much on the edge of it. So we just tipped our angle to do our core biopsies and were able to get the diagnosis that way. But the key here is that the anatomic landmark was right next to this small target. So let me show you this case. So this was a young woman who had a new diagnosis of breast cancer and a small single liver lesion. So everybody was worried about a metastasis. If you look at this CT scan that was obtained in planning the biopsy, we're kind of right at the hepatic vein confluence with the IVC.
Mm.
But when we compared it to her diagnostic CT scan from before, this was the lesion. And look at the arrangement of the hepatic veins. This looks much more inferior. The left and right hepatic veins have already bifurcated and they're much further from the IVC. And so, we had to kind of look twice, to ask ourselves, is this really the lesion? But it was. And so what happens is, the liver is only attached at the bare area and to some extent by the falciform ligament. And that actually allows a lot of rotation and movement of the liver in the subphrenic space. And it's always amazing to me how much the anatomical relationships can change. And of course, respiration is another factor and just body position. So the liver is quite mobile, as it turns out. And so using landmarks that are distant from your target, especially if it's a small target, can be very unreliable. And so it's important to realize that. We were lucky in this case that we could faintly see the lesion on CT and even on CT fluoro. And so we were able to get the diagnosis of a liver adenoma, which was good news for the patient in this case.
And we have to keep in mind the diagnostic CTs are usually performed with full inspiration. So whenever you're doing a CT guided procedure, all the landmarks are going to be changed because the patient's not going to be free breathing.
Absolutely.